Oh, before we sing. I was thinking after we sing. I mean, you know. I called. Hey, Len, are you with us? Oh, he's having trouble, I can see. Oh, poor old Len. He's on the web. He's off. He's here. He's there. I don't know what's going on. He's offline. He's online. All right. Let me start.
Check this. I'm on the phone and dropping. So, can you hear me?
We can hear you, but you just faded out again. What did you say, Peter?
I'm driving to a doctor's appointment and on the phone.
Okay.
So I'll be on for an hour and a half.
Okay.
3:30.
Okay. So did you get that, Jake? Peter's 01.
Yep, got him.
Okay.
We
And
have two other callers.
So yeah, we'll get everybody in a second. We got Peter, we've got Ron Shaheen, we've got Jake, we've got Dr. Steve, and me, and let's see, who else can I see? David Sibley, I can see. Who else? Oh man, there's a playing up here. Jerry Grimes, Larry Fish, Jerry Grimes, Larry Fish. Who else can I see who's not on the phone? Len. Hey Len, can you hear us yet?
Hello.
Len?
It's Eric.
Oh, it's Eric. Say something, Eric.
This is Eric. Can you see which number I am?
7.
Yeah.
7. Eric 7, Jake. Eric B.
Eric. Hello.
Hello. Who's that?
Ed.
Ed. Hi, Ed. Ed, have you been with us before, or is this the first time?
It's the first time.
Oh, welcome. And what's your last name?
Backe. B-A-C-K-E.
B-A-C-K-E. Okay, we'll be right back to you. We're just aggregating and getting people together here, and so just hang in with us for a few minutes.
Okay.
Did you get that, Jake? Oh, Don
Yes,
Price.
I did.
And I see Don Price's smiling face from Denver. Hello, Don Price. Ooh, we're going to have a big crew today, I can see. So, who else is on the telephone and would like to identify themselves?
Dennis Correa.
Hold on, Dennis. Was that you, Dennis?
Yes, it is.
Okay, number 2, Dennis Correa. Well, I may be seeing you sooner rather than later, Dennis. I got to be on the move, and I'm looking at Tucson all the time. So
It's a bustling place right now.
from your mouth to God's ears, it should bustle even more, and the rent should go up, but only after I've rented a place to live. Okay, who else is on the phone?
Hi, Rick.
I'm here, Larry Fish. You called my name. You mentioned my name.
Yeah, we got you. Who's on the phone?
Susan and Ron.
Okay, so hold on a minute. We've got Susan. Susan, say something so we can see what number you're on.
Susan and Ron.
Number 8. Number 8, Jake. Susan and Ron. Ron Severe and Susan LaHaye. Frank Kelly, what number are you on?
What number am I on? I'm on the telephone.
Number 9. Okay, Frank Kelly, number 9. What happens is that when you guys call in on the telephone, on the go-to meeting, it identifies you only as by a caller number. And when we see who you are, we can put your name in, and so it makes it easier to know who's speaking down the road. So if Although some of us, we have no problem recognizing, some of you we have no problem recognizing your voice. So we've still got 3 people to identify. Who else is on the telephone who'd like to identify?
Len Sierra.
Oh, Len Sierra. How
Finally, I made it.
Sierra.
Good to see you, Rick.
Okay, well,
Hey, Len.
Len, let's just get this over and done with, guys. Are we ready? On the count of 3. 1,
Oh, do it.
2,
Oh, do it.
3. Happy birthday to
you.
you. Happy birthday
Happy
to you. Happy
Happy birthday
to you.
Len.
Happy birthday to you.
That was kind of ugly.
That
Yeah.
was a bunch of sick guys. Ooh.
And you know what, Len?
I hope we're feeling better than we sound.
That's right. And Len, we're recording, so if you ever get a little nostalgia during the year and you want cheering up, just remember you can always come in and listen to the first 5 minutes of this call.
Well, that's not going to keep me up, Rick. That's going to depress me.
Okay.
How many birthdays?
68.
6.
You're not 70 yet. You're good.
No.
Well, happy birthday, Len.
He looks.
Be happy to make it 70.
He looks about 55. Put your video camera on so everybody can see how young you look, Len.
Well, I don't know if you can. Let's see. Can you see me yet?
No,
Nope.
we can't see you yet.
Well, hold on. Here we go. Here we go. How's that?
No, we can't see anything. We can't see you. Can you
I can see myself in the preview. Oh, share. I'm sorry. Share.
share? Oh,
There I am.
There he is.
Can you believe can you believe, guys, who can see him? This man is 68. Who can you believe that?
I told him that before. I couldn't believe it. He subbed for you one time, and I couldn't believe he was that age.
It's not fair.
It's not.
I do get that a lot, I have to admit.
Dr. Bornstein, you're the same age as that. He gives
I am. I'm 68.
And
I'm 68. I haven't fared as well as Len, though, I'm afraid.
he gives you a run for your money, doesn't he?
Well, it's
Yeah, I mean, he's got a full head of hair there, more than me.
70, hopefully.
Must have been due to clean living.
Yeah, no, I don't think so. That's not true.
Okay, so we've still got 3 people on the telephone. Anybody else on the telephone who hasn't identified themselves and would like to?
Sylvester Man.
Hello, Sylvester Man number 5. I feel like a bingo caller here. Anyone else on the phone that wants to?
Rick, it's Jim Harrington.
Hello, Jim Harrington. Long time no hear from you.
Well, I've been in Japan and Aruba, but I'm back.
Excuse me. I thought it was maybe because I gave you indigestion when I took you to the Chinese.
No, I've just been traveling a little bit.
Okay. Anyone else? Okay, so let me tell you who I know is on the call, and then we'll get started. We have 1 new gentleman and a couple of people that we haven't heard from, possibly 2 new people. We have Peter, who may have just dropped off, or he may be back, Peter Kafka, Ron Shaheen, Jake Hannum, Dr. Steve, David Sibley, and Mrs. Sibley, it looks like, as well. What Mrs. Sibley? Okay, somebody with David Sibley, Jerry Grimes, Larry Fish, Len Sierra, Ed Backey, Don Price, Dennis Correa, Susan and Ron Silvera, Frank Kelly, Sylvester Mann, Jim Harrington. Have I missed anybody?
Albert just joined.
I just got out.
Sorry, Albert just got on. So Albert?
Yeah.
Okay. And anybody else that I've missed? All right. So we'll run through. Number 11 is Albert.
Oh, okay. Oh, he is. He's on the phone and web.
I guess he's on the phone. Yes.
Yeah, the cam slots are taken.
Yeah.
And I've got to wait for one to open up.
Okay. All right.
All did drop out.
There you go.
Oh, you guys didn't have to get up.
Now we've got 2 slots open, so someone else can come back.
There we go. Oh, jeez, I didn't comb my hair.
And Dr. Steve can come back in if he likes.
Yeah, I'll come back.
You
I was being greedy, my spot. Okay, all right.
There you go. Now, let me ask, I know Ed Back is new. Jerry Grimes, Jerry, have you been with us before?
No, I have not. This is my first time.
Okay, well, welcome to you. We will start with the 2 new gentlemen. I think, if I'm not mistaken, everybody else has been on the call at least one time before. If not, speak now or forever hold your peace, because we're going to spend the next hour or so with Jerry Grimes and Ed Backey. Okay. And then I'll get to everybody else and check in who's got some questions and et cetera, et cetera. The only thing I want to check is that anybody that has to leave at the end of the first hour who has anything urgent that they would like to raise.
Rick, I'm going to have to leave in about an hour or so, but I have nothing urgent. We chatted earlier today as well.
Right.
So.
Right. Okay. Let's start with Ed Backey, since he was the first gentleman that we welcomed. Ed, as you well know, this I hope that this is the group for the AnCan Reluctant Brotherhood group for men with high-risk recurrent or advanced disease. And we're a group of fairly learned, experienced guys. We've covered, I think, pretty much every treatment that's out there between us in aggregate. And what we'd like to do is ask you to tell us a little bit about where you are in this journey, how old you are, where you're treated, your issues. I'd like to maybe, if you could just kick off, just tell us how you found out about us and how you know we're this meeting exists.
I got on the phone with us two that I get the monthly newsletter from.
Mm-hmm.
And I got on the phone with him, and he suggested I go on your website. I found the website, and I copied down everything that I could, and here I am.
Okay. Well,
I'm 79 years old.
Right.
I was diagnosed 13 years ago with prostate cancer.
Right.
I had a high PSA of 19 at the time it was diagnosed.
Right.
I went through high-density radiation with brachytherapy, IMRT. I have been down the road with Lupron. I have had, in the last 2, I have become hormone resistant 2 years ago, and I started on Xtandi. I was on Xtandi for 2 years. I went on Zytiga for 4 months, and Zytiga did not do a thing. My PSA kept going up, and next Tuesday I start the entry-level chemo with Doxtaxel and Taxotere, or Taxotere. And I guess my question is, I haven't been down the line with Taxotere. I don't know. The only answer I've gotten when I said, what can I expect, is that everybody is different. And I am fully aware of that. But I even look ahead toward after Taxotere. What happens if the Taxotere is successful in 6, 8, or 10 treatments? What kind of maintenance is there? What if it isn't effective? I guess I have some questions about the chemo itself.
Well, we can we've got a good group of people who are on this call to answer that, because we've got plenty of people that have been through the chemo. But let me just ask you a couple of questions first. Where are you located, Ed?
Outside of Springfield, Missouri.
Okay. And where are you being treated?
I'm being treated in Tulsa at the Cancer Treatment Center.
Okay. And is your treating medical oncologist, is he a specialist in genitourinary disease, cancers, or is he just a general medical oncologist?
I'm sure he's just a medical oncologist. I don't think he's a specialist.
Okay.
He's had some experience treating it, but I don't know if he's a specialist in that area.
Okay, so
I don't think so.
do you have to, are you able to get your chemo locally, or are you having to go to Tulsa for each session?
I've been in Tulsa 13 years, and I'm somewhat reluctant because of the ability to get blood reports, CT scans,
right,
within hours of when I take it.
Yeah.
And locally, the only experience I had is waiting and waiting and waiting. And that's not appropriate. That's just not what. But I can have it treated locally.
But by choice, you're going to go in and get all your chemos in Tulsa and go in and come back, essentially.
We're gonna try it. It's a 200-mile
right
distance each way.
Right.
We're gonna try it for at least the first time.
Okay.
And I have reassurance from my general practitioner that he would give me a referral to an oncologist in town.
Okay. Okay. So give us a little indication of what your PSA has been doing. I mean, you mentioned that 13 years ago it was 19.
Right. Lupron. I was on Lupron and Casodex with various vacations in between, and it came down to under 1 in the first 5 years. At the 5-year point, it jumped up to 5. I was off of Lupron for a while before that, so I went back on it. And let's see, 2 years ago, it went up to 13 or 14. And I went on Xtandi, and it brought it down to under 1 in the 2-year period. And then it climbed back up to 5, I think it was. And then after that, at that particular point, I've been on Zytiga for since November. I am off of it now, but for 4 months basically. And it went from 5 up to 12. It just steadily rose.
Okay.
And so I was taken off of that.
So you're
this is the next option.
You're around 12 right now.
Yes, sir.
And what?
And he would like
Go ahead.
He would like to catch it. He would like to catch it at that particular point rather than wait until it's higher than that and nothing has worked. I mean, the Zytiga was not working.
Right. And last question: what shows on your on your scans? CT scans, bone scans, any other sort of?
My bone scan is clear. My CT scan shows millimeters, 4 or 5 millimeters, something in one of the lungs, and that's about it. It's been clear. I am asymptomatic.
Right.
I have no pain.
Right.
I have no outside symptoms. It's I feel embarrassed because of that.
Don't ever feel embarrassed, because with this disease you never really know where it's going, and if you do know where it's going and you feel it, then it's a little late. So I think
right.
We're doing great. So I'm gonna because we've got so many guys really today. It's a great day that you've called in. We've got so many guys who have been on chemo. I'm gonna
Thank you.
Throw it open. And I don't know who would like to start. I know Dr. Steve is always a good person to start. And then we've got, just looking down my list, I think we've got at least 4 other guys that have been on chemo. So,
My goodness.
Steve, why don't you give Ed a little heads up about what to expect?
Okay, happy to, Ed. So I was on docetaxel, 6 cycles of it, ended about a year ago now. So and I think what your doctor said, saying it can vary in terms of side effects person to person, is very accurate. And so I can only speak to my own experience.
Right.
You know, I think the acute side effects like the nausea and the fatigue and so on are also very variable. I was a firm believer in taking some Zofran. I'm sure they've probably given you some of that preemptive, as well as the steroid that they typically use, dexamethasone. Yeah, either prednisone or dexamethasone, right? But I would certainly cycle. I would assume you're going to get nauseated, so take the Zofran. You know, hours beforehand. You may end up not needing it. It turns out I never got nauseated at all. The other common side effect that you might experience is the fatigue, but usually you get that after a few cycles as it impacts your blood count and your bone marrow. But I think I would sort of expect, and they'll monitor your blood count and see where you are on that one. I'd have to say, just speaking to my experience, and not any study on 1,000 people on docetaxel, it was relatively easy. I mean, I lost all my hair. Well, I had a few strands on the sides maybe, but I lost basically all my hair after about 2-3 months. And I had a pre-existing peripheral neuropathy, which is a numbness in the feet, and in my case, the bottom of the feet, sometimes the hands as well, but in my case, bottom of the feet. That I did acupuncture right prior to every infusion, and I think that helped. Although again, some of that maybe just I believe it helped. I don't know, but I think generally speaking, my experience wasn't nearly as bad as I thought it was going to be. I'm a gynecologist. That's why insist on calling me Dr. Steve, but I have a lot of experience treating patients with ovarian cancer and uterine cancers and so on, and on the platinum agents and others, and you tend to get a lot more nausea and vomiting with that. So I'd have to say my experience was better than I thought. I would not want to do it again, mainly because of the impact on the bone marrow and the fatigue and so on, but it was not overall as bad as I thought it was going to be, and they're probably going to give you 6 cycles and kind of see where you stand at that point. So that's kind of what
I was very reluctant to take chemo because my wife 22 years ago had mixed malarium sarcoma of the uterine and uterus, and she was on a most brutal chemo that it was a 24-hour chemo for 5 days, doxorubicin, platinol, and so forth, and it was I think one of the most brutal chemos that I've ever heard of. And she had 6 cycles of that, 5 days in the hospital as an inpatient. And that was my thinking when I remember her and giving her Neupogen shots every day for 11 days when she came out of the hospital. Now they got Neulasta, which he has said that he would like to use, which is the patch that you wear that delivers the basically Neupogen type white blood cell producer. But when I talked to him, I said, I'm really reluctant. He says, well, it's not like that chemo at all. And I said, well, that's the best news I could have, really.
Yeah, I have some sort of mixed Mullerian tumors, and it's not Taxotere, docetaxel is a far cry from the doxorubicin and the cisplatin, the stuff we used to use. So I think he's right. I think he's quite right. And there's some other, I'll let other people speak, but there's some other options as well as far as lowering dosages and spreading out intervals and so on if you have some bad side effects. But
well, she's a 22-year survivor, and I'll try anything to match her time if I can.
Let me ask who else would like to maybe give Ed some tips, some thoughts, what to expect. what happens as he gets through the process, how he's going to find the difference between the first, the second, the third, etc. Ron, you wanted to say something?
Yeah, hi Ed. This is Ron.
Hi.
I've had prostate cancer for 14 years. Have been through all the treatments and have been on chemo for 13 sessions, a little over a year.
My goodness. Uh-huh.
So I started on Taxotere, and it did nothing to lower my PSA for the first 3 months.
Okay.
When I started, hold on to your hat, I was at 800 my PSA.
Oh my goodness.
And we survived, you know.
Oh, bless you. My goodness.
And then I switched to Givtana, which is cabazitaxel, which is another chemo for prostate cancer. And my PSA started going down and went down to a low of about 142.
Oh my goodness.
I had relatively low side effects to the chemo. As Steve said, I lost my hair after about 3 sessions, and I don't know if you can see me if you're on TV or on the monitor.
No, I'm on the phone, but
okay. Well, my hair has grown back. It actually started growing back about after the 9th or 10th month, which was surprising to me. Yeah. And my biggest complaints about
it grew back straight though, rather than curly.
Well, it's the other way around, Richard. I actually have had straight hair all my life, and it grew back curly, which
really?
Oh my.
Yeah, quite different.
Looks very good. Looks very distinguished, I must say.
Yeah, yeah. So thank you very much. So anywho, as far as side effects are concerned, my biggest thing was I lost my sense of taste. Everything sort of tastes like cardboard and stuff. I'm on a 3-week cycle, so during the 3rd week, I'm feeling pretty good, and I have my glass of wine at night and celebrate that week. I don't have any wine the other periods of time. A little bit of constipation. The chemo can affect your white and red blood cells. I am borderline anemic, and that's just the chemo and the bone marrow and stuff, suppressing that.
Right, right.
I do take a Neulasta type of shot 7 days following my chemo. So if I have my chemo on Thursday, then I'm starting the day after on Saturday. I have 7 days of a shot of this drug, a different drug name, to build up the white blood cells. Very painless.
Right.
For a while, the first part of the year, I would work my way out of the Medicare bubble. And so with Kaiser, my cost of the medication was like $12. And then starting January the 1st, the 7 shots cost me $3,000.
I just spent $3,000 this January for Zytiga.
Yep. Well, I've done Zytiga and Xtandi, so that's what got me out of the bubble.
Okay. Yeah, it will.
Yeah. So Kaiser has a deal which uses nurse clinics. You can actually go in there, and they're 5 minutes from my house, and they'll give you a shot, and it's free. So
my goodness.
I'm electing to do that. Anyway, I would not fear the chemo. At the end of last year, I had another situation that made me very ill towards the end of November and December. So I stopped chemo effective January the 1st. And my PSA from January the 1st to February the 20th went back up to 800 from the 140. So I elected to go back on chemo, which I did. I had my second chemo this last week. And after the first chemo, my PSA went down 45 points. So I was very thrilled with that from the standpoint that it wasn't going up. I don't care how much it goes down as long as it doesn't go up.
That's right.
So my experience with chemo was I was willing to go back on it because the side effects to me were not that significant. That I would say, you know, I believe the chemo has given me another year or so of life. So it's been a positive for me. So that's my story.
Thank you.
And
thank you so much.
And Ron,
just one other comment about the Neulasta versus Neupogen. Neupogen is dirt cheap. It's also an injection, but it's given daily, and they can teach you to give it yourself, just like insulin.
Right.
Dirt cheap. Neulasta, some of the newer brand name sort of designer white blood cell enhancers are very, very expensive. So if it does cost you a lot of money to get the Neulasta, just go with Neupogen because it's dirt cheap. And it's the same drug.
Great, great. Great advice. Thank you.
Now, some other advice that some of the guys might mention to you is that you sound like a very fit 79-year-old. I forget how old are you, Ron Sheen?
74.
74. You sound like a very fit 79-year-old, but it is really.
I've been told I don't look a day over 78.
There you go. It's really smart, as best as you can, to keep your exercise up during your chemotherapy.
Okay.
Very.
I agree with that.
It will help you a great deal to minimize your fatigue. I mean, there's a lot of evidence. There's a lot of anecdotal evidence on this call, but the research suggests that if you can, get out if you have a regular exercise program, try not to stop it. Keep taking your walks during, if you can walk 15 minutes or do some aerobic every day. But we really here tend to try to encourage people to maintain a good exercise regime during their chemotherapy. Is there anybody else who's been on chemo who would like to add anything for Ed? No?
This is Dennis.
Yeah, this is Eric. Well, unless someone else wants to
go first Dennis, and then Ed, and we've got Ron Silverio, we've got Frank Kelly, we've got a bunch of people. We're going to spend about less than 10 minutes, and then we're going to move on. But why don't you go first, Mr.
Okay. This is Dennis, and I was diagnosed a little over a year ago at 70 years old with stage 4 metastatic prostate cancer, and immediately was started on the androgen deprivation therapy with Firmagon, and then very quickly thereafter the docetaxel 18-week chemo. Very similar to you, I didn't have any symptoms at the time, so this was all kind of scary. And as I was going through the chemo, there were times when I wanted to ask myself, boy, did I make the right decision with this? I feel terrible. I didn't have any problems before. Now I'm on the chemo, and it's pretty bad.
Yeah.
I did have a problem with the low white blood cell count, and ended up in the hospital for 5 days with neutropenia and multiple pulmonary embolisms in both lungs. And it was pretty painful. They got me through it. Ended up reducing my dosage a little bit, and of course added the Neulasta shot the day after shot to that.
Right.
And I was fortunate that I had the assistance of people at the Cancer Center here in Tucson, the University of Arizona Cancer Center. I had a dietitian at my disposal, so we spent a couple of sessions with her, and they brought a lot of information about the diet to help me, to get through this thing without the nausea and stuff. And also, there was a supportive care physician, not an alternative care, but supportive care.
Right.
And some of the things that came out of that, like she got me on a probiotic that helped me through the stuff. I'm still taking a probiotic, and it really worked wonders for me.
I'm at the Cancer Center in Tulsa.
Okay, to me that was a benefit of having she also recommended I was having trouble sleeping at night, so she recommended melatonin. So after doing that, that's helped. I'm using about a 10 milligram dose of melatonin every night. That helps me to sleep. But getting through that, and then after this, they switched me over to Lupron partway through after starting me on the Firmagon. And that's probably been a combination of the chemo and the Lupron, the fatigue issue. You know, I was 70 when I was diagnosed. A year later, I feel like I'm probably 80, but I'm still moving. I'm not, quitting on anything. I'm very active. I had no other health issues. Going back to playing 18 holes of golf twice a week and doing what I can to keep moving. That's the recommendations I have for you. So you can do it. It's not all that, when you're going through it, it seems bad, but after, it's, boy, what a relief. I'm done with that. And it was very effective. It got me from, my high was about 17, I think, on the PSA, and I'm less than 1 after about 4 3-month periods here after finishing the chemo. I'm still at less than 1 PSA.
My goodness.
So,
that's great.
I think that, what the take-home message from what Dennis told you, and I would jot this down when you go over to Tulsa, is to try and get what Dennis calls a supportive care. Some people call it symptom management. Some people call it palliative care. Palliative care does not mean end of life. But these are doctors who will help you with the side effects. So they'll prescribe the melatonin, or they'll give you ideas how to deal with the nausea. That might be a lot better than the oncologist, because that's their specialty. They work with side effects. And I know that many people who have been through this have been very grateful that they have placed a palliative care doc on their team early in the process. It's given them an extra avenue when they've had issues. And if you can sign up a palliative care doc, you might find it very helpful down the road. The other thing I want to mention to you, nobody's said it so far, is that you're probably going to find the first session you'll sail through. Maybe the second session, it's going to catch up with you by the third and the fourth session. And probably the fifth, although some people start to feel a lot better with the fifth. And by the sixth, it's almost like your body's adapted a little bit, so it isn't quite as hard on your body.
My goodness.
So don't be surprised if you don't feel anything to begin with, you suddenly get worse, and then you start to find you're tolerating it. That's a typical pattern. Eric, bookbinder, we're gonna finish up with you, and then we're gonna move on.
That is really good advice. I really appreciate that. That's great.
Okay, so I guess my tale is the other side of the story. I felt bad from the beginning, and I felt worse all the way through. I went for a week without eating. I went to the hospital. At one point, I went to the hospital 6 days straight to get hydrated.
My goodness.
I never wavered from my conviction that it was going to help, and so I had the 6 treatments, and 3 weeks apart, and that was now 2 years ago that I had my last treatment. 2 years ago in May.
Oh my goodness, that's great.
My hair did all fall out, but now I have a ponytail, so it does come back.
Oh my goodness.
I would just say take all the support that's offered to you. Anyone that offers to help you in any way, you let them do it because you'll need it. You may need it. As other people have said, it didn't affect them. But for me, I did have the food tasted like worse than cardboard, and I really just couldn't even swallow it. So I did some of the what Ensure, I guess they're called, but I really didn't like them. They're like almost entirely high fructose corn syrup. So I tried to avoid those after a little bit. But when nothing else would go down, I could usually choke down one or two of those.
My goodness.
But I came out of it okay. My PSA did go way down. There are some of us that don't produce much PSA ever. So the highest mine ever got was recently. It was at 10.7. But before that, my highs were 5, 6 area. And 3 months after I stopped, after my last dose, or maybe it was 4 months, my PSA went down below 1. And
my goodness.
It seemed like it was wonderful at the time, but then it started climbing back up. So that's really all what I have to tell you about it. I mean, don't.
Was that with or without your prostate?
Without. I've had the prostate removed. That was done pretty close to immediately 3 years ago, July of 2014.
So we could keep talking about this for another half an hour at least, if not more. But we need to move on. Ed, a couple of little things. One is we hope you'll come back to this call. If you would,
absolutely.
If you'd like us to add you to our distribution list, we send out a call reminder. I need your email. You can either give it me now, or if you're not comfortable doing that, I can give you my email address and you can send it to me.
I can give it to you now if you would like it.
Please.
It's EBBACKE at earthlink.net.
Got it. So EBBACKE at earthlink.net.
Yes, sir. Perfect.
So, all being well, there are people, I'm happy to connect you to any of these individuals or more so you can talk to them offline. Everybody's happy to on this call to support you however they can. You've got questions, we connect you. And like I say, most of the time, we can answer those questions. We can find an answer. So we're very glad to have you in this. Well, I know you're not so glad to be in this group, but we welcome you to it, and we hope that we'll get you through this, and we'll resolve whatever problems we can to bring you out the other side stronger and feeling better.
I can't thank you enough for it. I'm going to leave now, but okay. I appreciate so much the information. Thank you so much.
Okay. Okay.
Good luck.
Thank you.
Richard?
Yes.
Thank you.
I just want to ask Eric, what is he on now? What treatment is Eric on now?
Eric is on a trial. What I always forget. What's it called?
GS 5829.
That's it. GS 5829. It's an anti-androgen that kind of swamps the androgen receptors. I know Professor Bill is on here and he's explained it to us a couple of times. But basically that's it. But if you'll forgive me, I really want to move along so we can get to our other new gentleman, and then we have enough time because we've got a lot of people on the call today. Jerry Grimes, you heard the process. We're going to ask you.
I did.
Tell us a little bit about yourself. How did you hear about us?
I've been involved in the Us2 website for some time.
Also on Healing Well, my screen name on both of them is Redwing57. I've been participating on both for quite some time. I only found out about this call. Somebody, I think perhaps yourself, posted on Healing Well that there was going to be a conference call with Dr. Denmead, and that he was going to talk about the Transformer trial.
That's right.
That a friend of mine is embarking upon. So I was quite interested in that. And then I found out you guys have this call, and I thought it would be quite interesting to speak with you.
No, well, you're very welcome. Yeah, we do from time to time. We mention this call from time to time on Inspire, on the Us2 Inspire site. We don't post this one. We post the low one because we have so many people on this one already that we would just get get swamped. And we've actually gone from having this call every 2 weeks to having it every week. And at some point, we may even have to do it more than once a week. But
really? Okay.
But right now, yeah, that's where we are. And on Healing Well, we don't, again, the same reason we don't advertise it. I don't post a lot too often on Healing Well.
Right.
Okay, once in a blue moon I'll post on Healing Well. So please tell us about your situation and tell us you know, what you'd like to bounce off us or just share with us, or the floor is yours.
Okay, certainly. Thank you very much. I appreciate it. I'm 59 right now. I was diagnosed at 55 in April of 2013. Just an elevated PSA, and sent me to a biopsy. I had an annual PSA velocity of about 2.2. The level was only 5.2 when I had the biopsy. I wasn't terribly surprised that it came out positive, but the way it came out surprised me. I had six positive cores, all Gleason 9. A couple of them were 5+4, a couple of them were 100%. So it was pretty decent volume and quite high grade at the time. So MRI staged it as stage 3. The capsule was bulging, and there was evidence, you know, suggestive of it being outside the capsule and neurovascular bundle involvement and some fun things like that. So this was all at Vanderbilt. We were down in Nashville at the time, and I had radiation therapy, 44 sessions, IGRT, 79.2 grade total. Also had whole pelvic because of about a 40% chance of the lymph nodes being involved, just not showing yet, and so had them down to 50.4, kind of like Mac Roach has been in favor of doing. And then 3 years of hormone therapy. I was on Lupron and Caregivers for 3 years, both, so ADT2. And that all ended last March of 2016. During that whole time, my PSA was undetectable, which was great. So we came off of the hormone therapy, whole thing done with curative intent. I had a checkup in May, and the great news was my testosterone already then was up to 130 something, and the PSA was still undetectable, less than 0.1. In August, it was up to 0.2, and my testosterone had come up quite a bit. It's like 290. In December, the PSA was 0.5, and testosterone was 350. So, you know, both are going up. And then I just had it checked a week ago today, in fact, and it was at 0.7. So, you know, if it stabilized around 0.5, that'd be great, but it's looking a little trend-ish. And when I plotted all this, I'm an engineer, so I can't help myself. I have to do the math. So, you know, I plotted this on a log curve, and it's a dead straight line starting from last May. If I assume last May, which was undetectable, less than 0.1, the lowest it could have been was 0, so if I just say, well, call it 0.1. I put all those 4 points on a straight line, and all of the readings come out just on a dead straight line. And it has a 3-month doubling time on that line. My medical oncologist, I was seeing Dr. Hussein here at U of M, but she's moved on to Northwestern now, so I'm seeing Dr. David Smith there.
David who?
And he's David Smith.
Smith. Okay,
He's
yeah.
in the urologic oncology.
Yeah,
group.
yeah, I know who he is. Yeah.
Yeah, he does a lot of phase 1 trials and
yeah, yeah.
So he's been, aware, and he says, well, we'll check it again in June and see if it's up to a 1, and, if it is, maybe we'll do some scans or something. I thought, well, okay, but then I went and plotted it, and I thought, man, I'm not sure if we're waiting till June just so that we can see a trend. The trend looks pretty clear to me now, but the numbers are still pretty low, and there's about a plus or minus 0.1 variability on that number, so there could still be some ambiguity in it. So I contacted him and asked if we could move the next PSA checkup from June to, like May, and he said, yeah, that's fine. We'll see, because I project it'll be 1.2 to 1.3 if it continues at that same pace in May. And he said, well, if it is, then we'll, maybe do some scans and things and maybe do something from there. So I don't really have any feel for what he thinks the next thing to do would be other than hormone therapy at some point. So I guess what I would appreciate a little advice. I'm a little earlier in this than some of your folks that are already into the metastatic and chemo and so on. I'm still kind of back at it's definitely a very high-risk case, and is it in fact possibly recurring? And if it is, at what point would it make sense to do something like going back on hormone therapy, given the rate that it's grown and so on? I mean, I do have a little osteopenia, so there's that complication from the hormone I was already on.
You said you have a little osteopenia?
Yeah, it's a T-score of -2.
Okay, in -2 in your spine, in your hips, where?
Femur.
Femur.
Yeah, the hip.
Femur.
Yeah, the femur had the hip.
Right, and just one thing I didn't get, you're a little bit muffled there. I'm not really sure why, but how many grays did you say you got with your IMRT?
I'm sorry, it was 79.2.
Oh, that's much better. Thank you. Whoa, that's a huge difference. If it's the way you're holding the phone, that would be great if you could hold it in that place, tape it in that place.
That's better? Okay.
Oh, way
It must
better.
be. It's an iPhone. Oh, fantastic.
Way,
sorry about that.
Way better. I've been struggling to take notes here. Oh
dear, I'm sorry.
That's okay. Do you live in Ann Arbor?
I live not too far from there. I live in New Hudson. It's north of there, about 20 minutes.
Okay. It's really a great question that you ask. When do you intervene after that 2-year period? I mean, I had somewhat similar disease diagnosis. Fortunately, I was only 4+4 and not 5+4, and I did a boost with seeds rather than doing 44. I did a seed boost, and then I did my 2 years of Lupron, and I was pretty similar age to you. I was 56 at the time. And it really depends on the doc. I mean, some docs will intervene. I would say anywhere between about 2 and some a little less than 2, all the way up to, I've heard people that wait until you're at 10, which I don't get. Personally, I'm not a doc, but if it were me and that was my doc, I would not be very happy with him, because from what I know, I would intervene.
Yeah, I would not be comfortable waiting that long.
Right. So, it's, yes, we're seeing the doubling time. I mean, certainly you don't want to go more than 3 months, and if you're uncomfortable, take it to 2 months. Again, you need to ask Dr. Smith when he typically likes to intervene, but I could see him waiting a little bit more. When was the last time you got scanned?
Oh, you mean like a bone scan?
Yeah.
Oh gosh, that's that was probably baseline. I mean, that would have been back in 2013. I've never had a scan since then.
you know, the likelihood is it's not going to show much because your PSA is still so low, but you never know. That's probably what Dr. Smith is going to say to you. But
I have a question about that.
yes.
Gleason 9s are known for not putting out as much PSA as, say, a Gleason 7. So when they give these just simple PSA threshold numbers, are they taking into account the different levels of output of the types of cells involved?
Yeah, that's a great question again. I wouldn't say Gleason 9s are not known. I would say some Gleason 9s, some Gleason 8s, and some Gleason 7s. So it doesn't mean because it's a Gleason 9 it's not going to produce. Some people have Gleason 9s and they produce huge amounts. And other people have Gleason 9s and they produce very little. Eric, what were you diagnosed at? What were you a Gleason 9? I can't remember. Eric? Oh, he must have stepped away. I can look in my notes.
No, I'm here. What was your question?
What was your original Gleason?
I had some 9s, some 8s, and some 7s.
Yeah.
Mostly 8s.
Okay.
That was pre-surgery. After surgery, they upgraded it to more 9s.
Right.
5+4s.
So, you know, Eric's an example of somebody who doesn't make a lot of PSA. I don't know about Ron Shaheen's gone right now, but, you know, there are plenty of people I know that make high PSAs. One guy I'm thinking of in particular who got nailed with I think his PSA was around 200 or 300 at diagnosis, and he was a Gleason 9. So it really it does vary.
Okay, good.
But it's a really good question. How do you adapt? I don't know how you adapt. I mean, I've got a friend of mine locally who's been seeing Peter Carroll at UCSF for 8 years, and he had surgery, and his PSA, he was a Gleason 9, or he was a Gleason 8 or a Gleason 9 in post-pathology, and never made much PSA at all. I don't think his PSA was ever higher than about 1.5, and his PSA is slowly creeping up from like 0.01 to the last time it was 0.09. And, you know, he gets worried, and Peter Carroll says, no, you don't have to worry, you don't have to worry. But I understand why he's getting worried, because he still sees a creeping time. So I think the doubling time for people that don't make much PSA is probably the indicator. I mean, Eric would tell you that because he's seen his disease accelerate not by the volume of the PSA, but by the speed in which it's increasing. Let me throw it open to anybody that would like to talk about when to intervene.
How often do you have your PSA checked?
Mine was once every 3 months.
Okay, I do mine every 2 months. I've already had surgery. This is Peter. I've already had surgery and radiation, and my oncologist asked me to do it every 2 months, which I'm comfortable with. And I'm still down near the undetectable level.
Anybody else like to say anything to or to talk to Gary about when to intervene? We're getting feedback from someone. It might be you, Peter, possibly. That's better. Whoever it was that muted, I think, has helped us quite a bit.
Rick, this is Jim Harrington. You know, I'm also one who, as you and Eric know, that does not seem to make much PSA. My PSA right now is 2.4, and I've failed Xtandi, I've failed Zytiga. And it's actually never, over all the 8+ years that I've been battling this stuff, gone over 8. But again, you know, it doesn't mean that that's a good thing. It just means it's a little bit harder sometimes for the med-onc to figure out kind of where you are. Right now, I'm started this trial that I was telling you about, and sometime when you have time, I'd like to tell the guys about this trial, which involves pembrolizumab and listeria. And but right now, my PSA sits. Nothing much has happened, so I guess that's the good news. But I think I fall in the category of a guy who doesn't make a lot of this stuff, and I feel fine. Yet, if you look at my bone scans, I got bone mets all over the place, all in my spine, in my hip, in my neck, and CT scans show involvement with the lymph nodes. But I don't know. But I mean, but then again, I have no pain. So it's kind of an odd situation, and my med-onc loves to just punch me in the back. And
Jim, let me excuse me for interrupting, but I want to just sort of stay on the issue of how often to get tested. And
yeah, that's fine, Rick. No, I'm just saying that I just don't make a lot of PSA, and it just sort of sits there.
And when do you intervene? David Sibley, you sent me a note saying that you test monthly.
That's correct. I go in for an ex-Jiva shot monthly at my oncologist, and then he also does a blood draw and a PSA monthly.
And a Lupron.
And a what?
And a Lupron shot.
Oh, so you're on a 30-day Lupron shot, David?
Correct.
Interesting.
And we have a very slow PSA rising. He just got it back at 9, and they started him on Xtandi. And we also are going in to figure out what this cranial MRI is all about, because we don't really understand it. But it says there's a 2-millimeter spot that is suspicious for metastatic disease.
Metastatic disease. So
we didn't know what suspicious meant. What does that mean?
Well, let's come back, because we're going to go through everybody, and we'll try and spend some time with everybody. But I'm just trying to get some feedback here for Jeff Grimes as to when do you intervene? Anybody else want to say anything about when they would intervene after the initial treatment, or at what point their doctor decided that there had to be some intervention? Don Price, what was yours? I can't remember. You intervened pretty quickly, and then you went on to Xtandi pretty quickly, didn't you?
Zytiga, yeah, but mine was, you know, it was high risk because seminal vessel invasion. Right. And 4+3 and a margin, and so and so they just went ahead with you know, radiation and Firmagon. So, but that was just because it was considered to be high risk. So.
Anyone else want to chip in and talk to Jerry? Jerry, I mean,
it seems to be an unusual question. I've asked it on a couple of forums, and I've gotten a few responses, but it's the studies I can find online. For the most part, there's kind of an asterisk next to the results, and they say we don't know when the time is to restart.
Yeah.
It's up to the clinician.
Yeah. No, I think that you know it's not it's an art. It's the art of medicine rather than the science of medicine, and it really depends on your genitourinary medical oncologist. You have a good one, and you just have to trust him. I mean, you know, I've been through this with men who have been patients of people like Charles Ryan at UCSF, and again, sometimes they just decide to wait. If the PSA is moving up very slowly, they'll wait until it gets to a higher and higher level.
Right.
So it's hard to answer. I mean, what I would say is keep coming back to this forum. because we get all kinds of ideas. We've got lots of different people. There are people who have been faced with exactly what you're faced with. If I can think of some people to connect you with, I will definitely put them in touch with you.
Cool. I'd appreciate that.
My pleasure. And I'm going to ask you the same question that I asked Ed Backey, which is, if you'd like to give me your email address, I'm happy to add you to the distribution, so you'll get a note 2 or 3 days before each call.
Great. Yeah, that sounds great. It's GN Grimes, Golf November Grimes at gmail.com.
Okay, GJ, did you say?
GN, Golf November
Golf
Grimes.
November Grimes, got it. Okay, Golf November Grimes, Grimes, correct?
Correct. Yep.
At Gmail. All right, so we're going to move along.
I'd just like to close out real quick with a comment that Dr. Smith had made, which I thought was a great point. When I was asking him about this, he chuckles when he sees my graphs, and he sent me a note back when I sent one to him. He says, nice graph. But his comment was, we're not treating a number here, we're treating a disease. So we need to look at the whole situation, the patient, the disease, the numbers, the trends, and make decisions on that basis. So that's what I'm relying on with his clinical experience.
Yeah, you know, and I think that's as good a response as you'll get from any really well qualified GU med onc, and you've just got to trust him. But you know, I think that if you start getting up to high level, when I say high levels, you know, the 5s, the 6s, the 7s, then you start to get a little nervous. But where you are right now, if it were me, I'd be trusting Dr. Smith. So I'm going to, I'm just going to run down, I'm just going to run down my list. I know we've got some new people that have joined by phone. I don't know who they are, but let me tell you who I know is on the call or who has been on the call. A couple of people may have left. Peter Kafka, Ron Shaheen, Jake Hannum, Steve Bornstein, David Sibley, Jerry Grimes, Larry Fish, Len Sierra, Ed Backey, Don Price, Dennis Correa, Susan and Ron Silvera, Frank Kelly, Sylvester Mann, Jim Harrington, Albert Biasio, Bill Burhans, Ken Anderson. Anybody else? Is there anyone else who's joined us by phone? I've got 3 people on by phone I can see that I don't have names for. If you'd like to identify and you want to ask a question, let me know who you are. If not, feel free to just keep listening in. Okay. So let me run down my list and see who would like. I know some people on here have a few things to report. So let's see how many we can. And I would ask you today, since we've got a lot of people, we're probably going to have to be a little more concise. You'll have to bear with me if I need to cut you off so that we can get through everybody. Peter Kafka, anything for you?
No, I think I'm okay. I'll only be on for about another half hour.
Okay. Ron Shaheen, are you still with us? I don't see your picture anymore. Okay. Jake, anything for you?
No, Rick. I'll wait till next time.
Okay. Dr. Steve, anything you want to bring up before you leave?
No, my guest just got here, so I have to leave shortly.
Okay, no problem. David Sibley, you have something that you want to talk about. I've gathered that. So what?
No, I'd like to let the group know that I've gone through a immunotherapy session, and I've also had a MRI of the brain. So if anyone has any questions in those areas, feel free to ask.
So, David, what I'd like you, I'm going to put you down, and let's take some time to speak to you about and solve the questions that you're asking, or at least try and give you some input for the questions that we're asking. Larry Fish, anything for you? Larry, you still with us? Okay. Len Sierra, anything for you, Len?
No, thanks, Rick.
Okay. Don Price, anything for you?
No, I'm good. Thank you, Rick.
Okay. Dennis Correa, anything for you?
I'm good, Rick. Thank you.
Okay. Susan and Ron, anything for you?
Yes, Rick. I'd like to give you a little update.
Okay, great. We'll be with you. Frank, how about yourself? Anything for you to tell us from the northern realms of Idaho?
Well, I'm having some problems with blood pressure. I'm on cabazitaxel. I didn't have the problem when I was on docetaxel. And it's actually a very high, serious problem. I've had it in the past, but it was under control for 3 years.
Okay.
Just wondering whether or not anybody else has blood pressure problems with some of these things.
Okay, so we'll come back and we'll try to talk to you. Sylvester, anything for you today?
Did she put this on you? Not at this time. Thank you.
No. Jim Harrington, definitely you've said you'd like to tell us a little bit about Listeria trial.
Yeah, I mean, I can also wait with that, you know. I mean, it's just, I'd like to bring this somewhat unusual trial to the men.
Sure.
But, I mean, if there's time at the end, I'll be happy to talk about it. Yeah,
Okay.
it's quite something.
Okay. Albert, you can just give us a quick fill-in of what's been happening this week? So
yeah,
I'll come back to you, and you can just let the guys know where you are and what's developed this week. Professor Bill, anything for you?
Nothing for me.
Thank you, thank you. Ken Anderson, you want to just give the guys a quick update of what happened when you went to MD Anderson?
Yeah, sure I can.
Thank you. Okay. Have I missed anybody? Is there anybody's name I haven't called who would like to bring something up?
Yeah, Tom Van Zandt, and I just have a quick comment.
Oh, Tom, that's right. I'm sorry. I thought I wrote you down and I did not. Okay. Anybody other than Tom?
This is Eric. I don't think you mentioned me, but I'll just pass this week anyway.
Oh, I'm sorry, Eric. You're right. I didn't. I beg your pardon. Sorry about that. Okay, so let's start with. We've got about 50 minutes here, so hopefully we can get through most of you. David, why don't you just tell us a little bit about what immunotherapy you've been considering, and I know you've got an issue as to what exactly they're going to be looking for.
Okay. I had a immunotherapy. It was called Provenge.
Okay.
And that started in December and ended in January of this year.
Right.
And
I should just say, let me just interrupt. We're very familiar with the process. We've got probably 4 or 5 guys who have been on it. So
okay.
How did you do on it? And did you sail through it, or were you one of these guys who had problems with hydration, or how did you manage?
Actually, I had no problems. The biggest problem was doing the cell collection for 3.5 hours, you know.
Right.
And but other than that, the process went well. And the oncologist is telling me it's too early to do a PET scan to see if it worked, because the immunotherapy, I was told, will not affect the PSA at all.
That's right.
So.
That's right. Steve, do you want to just talk a little bit about, give Dave, by the way, lives in Castro Valley, so he's closer to you than he is to me.
Yeah.
And you want to give him a little feel for how you're dealing with the issue of knowing what sort of effect it's had?
Yeah, no, I finished Provenge recently, but you're absolutely right. There's no impact on PSA. I think the Provenge, you look at the clinical trials with Provenge, it was most effective with men who had a minimal tumor burden, which is to say a PSA less than 20. That's where it seemed to hit the sweet spot. I don't know, David, where you are there, but that was certainly the sweet spot. I think, I'm not sure it's your wife or the woman sitting next to you. Anyway, I guess you had some questions about an MRI that showed a possible metastatic lesion in those. That might be on your...
That's correct. This is my daughter, Christine. And
I'm sorry.
I'm
sorry. I thought maybe young wife. I don't know. You know.
His PSA currently is 9.4, and after the Provenge, it did continue to go up very slowly. He's never been a real high PSA. His highest ever was 37 at the very beginning. And then he went to a lady at a support group, and she said, well, he had one episode of vision problem, so we pushed for an MRI. And the lady said we should push for the MRI on the brain. So we did, but he's never had an MRI on any other part of the body. And now it's supposedly showing this issue of that 2 millimeter suspicious for metastatic disease. I don't know, I could show it to you.
No, you know, it's fine. It's fine. Yeah.
We're not really going to be able to see that. And when you say that there's a 2-meter lesion, where are they seeing this lesion? This is from the brain scan?
Yeah, it's on the cortex of the right posterior frontal lobe. A punctuate focus of flare, hyperintensity, and enhancement at the cortex of the right posterior frontal lobe.
And when was the last time you had an MRI or CT scan or bone scan for the rest of your body?
Well, I had a CT scan July 5th, 2015, and I had a PET scan August of 2016.
And David, there's no other visceral metastasis, in other words, liver and lungs, were clear on the CT scan?
Clear.
Yeah, correct at that time.
Yeah. Well, you know, I can't comment from a medical standpoint. I am a physician, but I can't. A gynecologist is not where you want to get advice here exactly, but it's you know, I think it. Having dealt with a lot of imaging studies, including MRIs over the years, it could be very worrisome. It could be an artifact. You know, it's a very 2 millimeters is very small, and the fact that you have no other visceral metastases, your PSA is going up. Is that the deal?
Very slowly.
Yeah, yeah. I mean, it certainly needs to be followed, and it's worrisome enough. You had some double vision or something. What was the symptom you had to?
Blurred vision in one eye.
Blurred vision, yeah. So you did have some.
Left eye, right?
Yeah. So that, you know, it could be optical nerve. So there could be. I mean, yeah. It's. I don't know what your doctor told you about it. Are they going to just repeat it, or what are they going to do?
They referred us to see a radio oncologist.
Radiation
oncologist. So they're thinking it is real then. A radiation oncologist? Yeah, yeah. Because that would be the treatment, is to radiate it probably if it is real.
Yeah, and they were talking about cyber knife or gamma knife.
Yeah, yeah. And I have gone through that as well. I mean, not on the brain, but cyber knife and other such computerized radiation oncology tools are very, very precise. That's their hallmark, and so you can treat something without damaging the surrounding tissue. But certainly worrisome. You know, the Provenge, of course, is not going to impact visceral metastases. It's not designed for that. So, you know, it's the other option is some type of chemo, of course. So.
Would you push for a MRI for the rest of the body before you made that analysis?
No, the CT, my understanding, again, is the CT for other soft tissues, liver and lungs. I mean, most commonly, prostate cancer goes to bone by far, and then less commonly liver and lungs, and even less common will it go to brain. But if the CT was negative for other metastases to liver into the lungs, then this is it's an unusual situation for sure. I would definitely pin down the radiation oncologist to make sure that they're treating a metastatic lesion and not just some artifact or something else, because 2 millimeters is pretty small.
I'm not a doc, but maybe I see it a little differently. The lesion, the CT scan that you did was a couple of years back, is my understanding, right?
Yes.
Yes.
And although it's a little unusual, metastasis to the skull is not uncommon. And there are men that I've known whose first diagnosis was to the skull. Dan Louis, who is often on this call, who happens to live in San Francisco, is one of those people. So it's possible that there could be something going on. And I think at this point, especially after Provenge, and having not been scanned, bone scan or CT, and I don't know what sort of PET scan you had, but it might not be a bad idea to get some new scans just to make sure that there aren't any bone spots anywhere. The Provenge, again, I would beg to differ a little bit with Steve about how the Provenge affects soft metastasis, because we've actually seen in biopsies how the Provenge can surround a tumor even when it's in soft tissue. So it's possible that it could surround that tumor wherever the tumor was. It has the ability to surround the tumor, and then it kind of, it's like wagons circling with the tumor is the campfire and the wagons circle it, and then it just can't escape. I mean, that's sort of very elementary way of describing how it works. So I mean, I think I probably would be pushing. We've had this discussion before, but given where you are in Castro Valley, I really think that you need to be seeing, you need to tap on the expertise at UCSF, because that's where they're going to see way more. I mean, that's where I would want to get my radiation done if you can access it. I know you're with local people there, and you need people who see this all the time and deal specifically with prostate cancer. And you have one of the best possible places in the whole of the country to go to. And I would just encourage you to think about getting a consult at UCSF. I'd be happy to connect you to some people that might be able to provide the consult.
So David, there's no bone disease? Is that, we had a bone scan and there's no bone metastases?
No, they caught that in the beginning. There was bone metastases to the pelvic area and the ribs.
Oh, there was?
Yeah, so Rick, the other thing is when you have a metastasis to the skull, what's called the calvarium, it's very, very easy to differentiate that from the brain, the parenchyma of the brain on an MRI. They're not confusing a skull metastasis with a
No. I wasn't saying, what I was saying was that the bone metastasis might not show on the MRI, but the soft tissue metastasis would, or is that not possible?
The MRI is much better for soft tissue CT for bony lesion. But I agree, I didn't realize it was a year and a half, and I think what Rick is saying, I absolutely agree that having a restaging CT scans done of your liver, lungs, bones, obviously, to look for other soft tissue, specifically liver and lungs, would be very worthwhile, because if they do find something, you don't want to willy-nilly be radiating your brain. There may be other treatments at that point. And I absolutely agree. I don't know where you go in Castro Valley or who you see, but I absolutely agree that seeing someone at UCSF, at least for a second opinion, would be a very, very good idea.
Thank you so much for taking your time on this matter. I know you guys have a lot to move on to, so.
And David, feel free to call me, to be in touch if you need a referral. I'm 99% certain, but you're not a Kaiser patient, right?
No.
No.
Okay. So yeah, feel free to reach out to me. You can call me and we can talk, and I can give you some help as to how to get into the system. But I really would want you to seriously consider getting a consult at UCSF.
I think I'll do that. Yes.
Okay, just be in touch with me, and we can work a little bit on that. So let me move on.
Thank you.
Pleasure. Let me move on to Susan and Ron. Susan, you're up, or is Ron going to talk to us?
Hi, I'm going to talk to you, Rick.
Okay, all right.
I just completed my third Zofiga, and I'm going to be seeing, I got scanned today, CT scan. I'm going to get a bone scan on Wednesday. I'm going to see my oncologist on Friday, and the first week in April, I'm going over to Hopkins to talk to Dr. Antonarakis.
Okay.
And right now I'm on just the Zofiga and Xtandi.
Okay.
And as of late, my PSA has started to skyrocket. I mean, when I was initially diagnosed back in 2012, it was 42. Now it's back up to 50. And they brought it back down to like point something, 0.0 something during the treatments way back when. So Antonarakis' worry is that with the Zofiga, I got a lot of cancer floating around in the blood, and he wanted me to get the scans to make sure it's not in other areas, and then we'd have to treat those areas and then go back to the Zofiga. I talked to the guys that gave out the Zofiga, and they said, well, unless the tumor's really big, then we don't deal with it. You know what I mean? We just keep giving you the shots. And my oncologist locally wants to put me on an old-fashioned chemotherapy. And I said, oh, yeah, what's the side effects of that? She said, you'll lose your hair, and it could cause heart problems. So I don't know she never did give me the name of that stuff, so I'll get that this Friday.
Yeah,
that's where I stand.
I think I know the name of it, and I can't. Steve, can you remember?
It's probably platinum-based, I'm thinking. Is it not cisplatin or carboplatinum?
She never mentioned. She just said it was old-fashioned.
Yeah, no, I mean, it could be one of the platinum-based ones, but I was also thinking there was, what was the one that they used to use before docetaxel that wasn't platinum-based?
Well, there's Cytoxan, which was a really old drug. I know one of the fellows here had been on that. I'm not really sure what they were using.
I can't.
Ketoconazole?
Which one?
Ketoconazole?
No, that's a anti-androgen.
Yeah, that's not Abitaxel, is it?
No,
Abitaxel?
No, that's a new drug. So I think I know what it's either a platinum, as it says, which would make a lot of sense. But I would say that if anybody's going to prescribe a platinum to you, you'd want it to be Antonarakis.
Right.
Because first of all, we don't know what's going on in terms of trials there. Secondly, you may be a good candidate for bipolar androgen therapy. And and I know that Antonarakis mentioned it to you once before. It has to be done under real close supervision. There's a question of what you're going to be taking alternatively, whether it's going to be, just high dose and then nothing, or high dose then Xtandi, then high dose. But you want to talk with him, and what you don't want to do is get stuck with a chemo regime like the platins that might interfere with what's on Antanerakis' mind. Does he or will he talk to your local oncologist? Is there communication?
Oh, yeah, he would, yes.
Okay. So, you know, I think that when in April is your Antanerakis appointment?
The 5th.
Okay, so it's coming up pretty soon. It's not like...
Right.
So, you know, my feeling is, if it were me, I'd probably be wanting to see Antanerakis first, and then I would have Antanerakis and your local person in Delaware huddle with you, in Dover, and huddle with you, and then decide between them what they think is the best, and see what.
Okay.
Anybody else want to speak to?
I have a question.
Yeah.
Ron, you're on Xtandi, but you're not on Lupron?
Oh, no, I take Lupron and Xgeva every 3 months. I mean, yeah, every 3 months. Yeah.
Okay.
Someone else?
Well, just Ron, one other quick thing. I think as far as the radium treatments, the Xofigo, you don't have to take all 6 dosages by any means. If you've had 3, I would certainly explore whether you have other areas of concern rather than go after the bone metastases only. So you can certainly do. That's what I did. I took 3, and I kept the other 3 in my back pocket in case I needed it.
Okay.
Really, no reason other than the clinical trial that you need to take all 6 dosages if it's worked after 3.
Right.
Mm-hmm.
Okay, sounds good.
I mean, that's really good advice. How are your blood counts doing with the Xofigo?
Fine.
Good.
Yep.
We like that.
No problems. Everything's in the proper zones.
We like that. By the way, I think it's today or tomorrow, our Aussie buddy, our Down Under buddy, Jim Marshall, is going before the Parliament to try and convince them to make Xofigo available to our friends down under. So, yeah, he's doing a lot of advocacy there to try and give them access to some of the drugs that we see here. So God bless him.
Yes.
Okay, anyone else? Anyone else before we move on to Frank Kelly? I'm going to say anyone else. I mean, anyone else want to say anything to Ron and Susan before we move on? Okay. Frank Kelly, you got blood pressure problems, man. On cabazitaxel, is that right?
Yeah, the first 2 weeks of, or first 2 sessions of cabazitaxel didn't have a problem. Third week, second week of the 3rd round of cabazitaxel, all of a sudden I was getting high readings of close to 200 over close to above 100, and then occasionally I'd have a 78 over 50. We checked the pressure cuff to make sure it coincided with the doctor's one, and it was within a pound or 2, so we figured that wasn't a problem. I changed the batteries in the thing. But right now I'm reading, and I'm working with a nephrologist. She doubled my dose on the high blood pressure medicine that I'm on, and that was middle of last week, and I'm not seeing any improvement. Got a call into her. They were supposed to call back today. I'm just wondering whether anybody else has had. I had high blood pressure. That's how they discovered my prostate cancer. I went in for headaches and things like that, and I had like a 250 over 125. But since then, it's been under control. 130 over 77, that kind of thing, until all of a sudden last week, boom, it started moving up and down, up and down, up and down, which I'm sure is not good for me, let alone the high blood pressure. But I'm just wondering if anybody has had any other problems with the Taxils. Never had a problem with the docetaxel. My blood work seems to be pretty good. A few things a little bit low, but not way low. So I'm in the strike zone on most of that. Just wondering if anybody's ever had any problem with some of these chemos with this.
Well, I know that Ron Shaheen is on cabazitaxel right now, but he's left us at this point. But you can send him a note. I'll be sure to send Lisa Ron Shaheen's address, his email address, so that you can ask him. Ron Shaheen for Frank. Sorry, I'm just making notes so I don't forget. Is anybody else on the call who's been on any sort of taxane-based chemo had? I know Eric's had low blood pressure problems. Has anybody had high blood pressure problems? I think there's your answer from this group, Frank, and we've got, as you heard.
Well, they cross-referenced all my drugs just to see. I'm on prednisone, and I'm on this to see whether or not there's anything that pops up. Prednisone can pop up headaches,
right?
But they don't affect your blood pressure, and nothing comes back on cabazitaxel. Cabazitaxel.
It's cabazitaxel, C-A-B-A-Z-I, cabazitaxel.
Okay.
Say Jeff Tanner, it's easier.
Okay. Well, I just say the other Taxel versus the one. But anyway, there's nothing as far as side effects, etc., that come up on the drugs that I'm on.
Yeah. Well, you know, there could be a drug. There could be a drug interaction. Unfortunately, Steve had to go because he's the man that probably would know about the interactions. What does your local medonc say about this? He's the guy.
We haven't seen him yet because I've got a new one, and now he's on a every 3 month program. Even though I get injections of the cabazitaxel once every 3 weeks.
Infusions, not injections, right?
Pardon?
You said injections. Did you mean injections or
infusion? Infusion.
Well, you know, here's what I would strongly recommend, and I know this is what I would be doing. I'd be getting his attention. You have every reason to get his attention. You need to talk to him. He's the doctor who knows how taxanes affect the body. He's the doctor that's going to be responsible if there are any interactions. And a lot of times there are interactions. And so the person to be asking, the first person to be asking, not the nephrologist, not anybody else, is the doctor who prescribed the taxane. And that would be your new guy. And, you know, you need to reach out to him and set up a call with him, send him an email right away tonight and tell him what's going on. He needs to know.
Okay. I see him, well, I don't know if I see him or not, but a week from today I'm supposed to have another.
Yeah, but I mean, you know, if this is going on, if this is going on, I can't give you better navigation than to speak to your medical team. I mean, this is urgent. I mean, Professor Bill, what would you say on something like this? He's still with us? We may have lost Bill. But I think if Bill, I mean, you know, I'm like those lawyers who only ask a question if they know what answer they're going to get. That's why I asked Professor Bill. Because I know he'd be saying, yeah, you know, you got to go talk to your doctors. Is there anybody else on the call who wants to address this with Frank?
Yeah, I wanted to say that I had, you know, somewhat similar where when I first went on Lupron, I was getting it from, not from the oncologist, but from the, what do you call it, the one that removes your prostate? Urologist, yeah. So he was giving me the Lupron, and I started to get some reactions to the Lupron, and I called his office, and their reaction there was, well, talk to your oncologist about that. And I said, wait a minute, you're the one giving me the Lupron. So that was the end of my relationship with that guy. And I just go to the oncologist, and I get the Lupron from him now. You know? So if they're not going to be responsible, if they're not going to deal with side effects, I don't want anything to do with them.
I kind of had the same reaction to my urologist, fired him, and I haven't seen him since. That's why I see a nephrologist, because in his door he has a internist. So the internist is my primary care doctor.
Anyone else with any thoughts on?
This is Bill Burhans. I heard
Yes,
my
sir.
name from the other side of the room. I'm sorry.
Yeah.
I left momentarily, but what was the question?
Well, Frank is wrestling with high blood pressure, which seems to have started after the second or third round of cabazitaxel, Jeff Tanner, and very high. I mean, 200 over how much, Frank?
Usually over 100.
200 over 100, but then sometimes it goes down a lot. But this has been going on now for the last week, 2 weeks?
2 weeks.
2 weeks. And so my suggestion to him was, well, the first stop should be with the medical oncologist who prescribed the taxane, the cabazitaxel, because he's the guy that's going to understand the side effects. And as yet, Frank hasn't spoken to him, and I'm urging him to speak to that guy right away. And I'm saying, what would you do, Bill?
Okay, that's exactly what I would do. And if I didn't get any satisfaction speaking with the medical oncologist, I think I'd take the problem to my primary care physician, not because I think that they might be able to answer, but they might have some ideas about how to get the right answer. But it's the oncologist is the one who prescribed it should know the answer to that question.
Well, we've made phone calls and yet to get return phone calls from them. So we'll have to push the button a little harder. Yes.
Well, I think you do. Yeah, I think you've got to call his office and say, I'm having a medical emergency. I need to speak to my oncologist.
Absolutely, and it is a medical emergency with blood pressure that high.
Yeah.
Yikes! You really need to do something fast.
Right. Okay. And you know, if you just call and say, well, I'd like to talk to you, can you call me back? He probably may not if he's not that responsive. On the other hand, if you call and say, hey, I've got some real issues here, I've got to talk to somebody right away, I think they'll get back to you. Lisa knows how to do that.
We've tried with the nurse and it didn't happen. So
yeah, well, then you've got to go above the nurse and call and say, I need to talk to the practice manager. I mean, you've got a great terrier in your court there. And she'll make it happen. But I think you've got to be pushy. If you need help, call me. But you've got to be pushy and you've got to say, I really need to speak to somebody right away. Because he prescribed that drug.
What just out of curiosity, when the low number is high, I know that's when your heart is at rest, but what kind of effects can that have on your body?
I don't know enough.
Nothing good.
Okay, that's what everybody tells me. They don't really know what the low number does. Okay.
And anybody have input onto that? Again, we lost our medical expert to a beef stew, I think, from what he told me when we were speaking earlier today.
Well, this is Jake. My understanding is the high number was when your heart is pumping, and the low number is when it's resting, and that's why it's dangerous. The low number is especially dangerous because it's not relaxing the way it should be. Okay. That's my layman's understanding. Frank, since I'm on the line, are you on any kind of beta blocker or anything for blood pressure now?
I'm on clonidine patches. I'm on pills. Huh? Lisinopril.
Is that for blood pressure?
Yeah,
that is. Yep.
So I'm on like 3 or 4 different things, and I have been real stable for the 3 years that I've been on them. It just all of a sudden this came up with the cabazitaxel.
Cabazitaxel, yeah. Well, I think that's why. Don't want to sound like a broken record, but you've got to get a hold of that med-onc tomorrow, and I'll try and remember to check in with you and see how you're doing on that. But if not, let us know, and we'll move him off the dime pretty quickly. He's got to talk to
you. This is, I'd just like to emphasize, this is a very urgent situation. You really need to get it taken care of quickly.
Okay, thank you very much. I thought it was, but nobody seemed to be in a hurry to help it.
Yeah. So let's, Frank, I'll talk to you, or give me an update in a couple of days, and let me know what's going on and if I can be of help. We're gonna.
I'll give you grief on Thursday, Frank.
Okay. Just one good news out of the cabazitaxel is that my PSA has gone from 6.8 down to 3.
Oh wow!
In each sessions. So it's actually working one way, but it's messing something up the other way. I'm wondering whether it's messing up my kidney.
Well, you're talking to the nephrologist. Are they doing tests?
Well, like she said, she doubled my, not doubled, 50% up my one drug, and that was towards the end of the week, and through the weekend I saw all this happening that wasn't changing anything. So I put a call into her yesterday and never got a return call, so I need to call her back tomorrow.
Yeah, I mean, I just think you've got to keep pushing these people and tell them that you've got what might be a medical emergency, and you need some attention, and you just got to stay on them. So
thank God I'm not down in Tucson. I was supposed to be down in Tucson, so we all decided it wasn't worth the risk of traveling.
No, I would have gotten you to look at a couple of places for me that I'm thinking of moving to. I could have used Lisa down there this week.
It was 90 degrees. It's 90 degrees down there.
No, one of them was right next to Canyon Ranch too. I would have had you go over and check out the house and see if it was nice. Okay, we're gonna keep moving. We've got 15 minutes. Jim, Jim Harrington, I'm going to, I personally would love to hear about this listeria, but I may ask you to just hang on for next time because we're running out of time here. Albert, just tell us very quickly.
And by the way, that's okay, Rick. It's really fine. I can talk about the trial since it's ongoing for a long time now at a later time. No problem.
Okay. Albert, give us a quick update on what's been going on this past week from you, since there have been things going on. And if you can fill Bill in, because I don't know if he knows the latest stuff.
Okay. I got the genomic testing back, and they did find the BRCA2 mutation. Now, it's funny because 2 doctors got that. I was in the process of going for a second opinion to begin with. The doctor with a second opinion said, yep, you've got a BRCA2 mutation, and I think we have, and you know the name of the medication better than me, Rick. We do have medication that will attack it. The other doctor said, no, we got to go to chemo. So I kind of dumped him and went with the one that would give me the medication, the pill. What is strange is that insurance turned it down, Blue Shield, Blue Cross, and then the what was the second one? You go through three insurance.
It was the manufacturers, AstraZeneca, who make Lynparza, olaparib, who I think the hospital applied to, but you...
Yeah, the pharmaceutical company. So now I just talked to the financial coordinator. What are you doing?
I'm making faces at Tom Van Zandt because he's making faces at me.
Okay.
Sorry.
I did talk to the financial coordinator, and they went ahead and put into the company itself now, and they said wait about a week and we should start hearing something.
So who was it that turned you down? Who was it that turned you down and said you're making too much money if it wasn't the company itself?
There was Avilica. It's one of the specialty pharmaceuticals.
Okay. So it was a specialty pharmaceutical company that must have its own subsidy program, and they said no, so now they've gone to AstraZeneca, correct?
Yeah. So I'm getting with the financial coordinator tomorrow or the day after and try to get all this straightened out.
Okay. So, now, what about, we talked about you appealing the insurance company. Is that, that's what Bill and I think is probably maybe effective.
Yeah, there's a funny thing there. I finally got through to her today because I wasn't getting any information, any communications back or forth from her. And she goes, and I go, look, these guys have sent me, some people have sent me some very good information. And she goes, well, we know that already. It's the insurance companies that don't know it. So I must have ruffled her feathers, something like that.
Who said
the financial coordinator
at the hospital?
She got on her feet, so I must have stepped on her toes somehow. So I'm going to buy her some roses or something tomorrow.
Okay, but the fact is,
why I don't. This is Bill speaking. I don't understand why the financial coordinator is dealing with the insurance company. Your doctor should be writing the appeal letter. He's the one that would understand.
That's what I'm going to find out, because I haven't gotten any communications from any of these people. That's the way I thought it'd be, but I guess at this hospital, they do it a little bit different. And as soon as I get more information on the logistics, I'll let you know.
Okay.
The other thing is, have you talked to your human resources people at your company?
No, I didn't have a chance today, but I will tomorrow.
Okay, so because they are the ones that should be helping you with the appeal to the insurance company too.
Right. Okay.
All right, and I say that on the basis of when I've seen other men who have been parts of large insurance policies. Their HR department has been very helpful in working with the medical team to appeal. So, you know, I think you've got to work with the hospital, with your own HR people, and you've got to make the appeal to the insurance company. I don't know that anybody has even started an appeal to the insurance company yet. It may be that the hospital heard the insurance company turn it down, and then they went to see if you could get subsidized with the pharmacy, and now they're going to see if you get subsidized with the company. I mean, these are all the easy outs. They should be working with the
company. This is what it seems like.
Yeah. Again, you know, you've got to put pressure on them. If you want, you know, me to get involved, we can talk about that. But it doesn't seem like they're going through all the channels, and they should be going through all the channels. They don't have the time to mess around, okay? And your doctor's aware that you can start taking the drug right now, correct?
As far as I know, yes.
Okay, you need to tell him, are you on a lap, have you started a laprid or not?
No, not yet.
Okay.
So I'll see him tomorrow. And
okay, so you let him know that you know, you'll let him know that if he needs, you can get onto it, and in the meantime, and lean on the doctor too. You know, the doctor, the person,
This is Bill Burhans. The doctor is the most important one. Yeah. He's the one that needs to write the appeal letter, because he's the one that's going to know, you know, all the background information in order to convince the insurance company that there is reason to think that this drug is going to work.
Okay.
All right. And be sure that they've seen the information that Bill sent to you.
Right.
Okay. All right. We're going to keep moving. Ken Anderson, give us a quick update. If you're still with us, give us a quick update on how you did at MD Anderson last week.
Yeah, I am still here. Basically, you know, Dr. Korn is the gentleman that I saw at MD Anderson, and he's agreed to be aggressive in regards to treatment in general. Seems that MD Anderson is more of a they prefer doing single-line Lupron, no Cosadax or Casodex at the same time. In addition, he's recommended that I start chemotherapy within 2 to 4 weeks, and I'm not sure which chemo, but some chemotherapy, and we're trying to figure out where here locally that I can do this, whether it be the location where the oncologist is that I've seen here in Scottsdale in the past, or some other new guy. We haven't really decided yet, and I'm going to have a conversation with him within the next couple of days. In addition, he'll give me the kind of what to do plan of attack, the stuff that I need to do apparently.
Okay.
So that's about it in a nutshell in my mind.
Yeah. I mean, so for those of you who don't know, Ken was diagnosed, when was it? Around the beginning of January, the end of December, correct?
It was February 15th.
February 15th, right, was when you had the, that's when with the biopsy slides came back with metastasized prostate cancer with some bone involvement, and so going to just figuring out what kind of attack to take, and so that was why he was down there. And yeah, I mean, I think logistically, it's just really important to figure out a comfortable place for you to get the chemo locally.
Hey, Rick, this is Dennis. You know, my oncologist that I had down in Tucson, Dr. Parminder Singh, is up at the Mayo Clinic up there near Ken. So, I mean, that might be an option. I was very pleased, and he's the one that I, started with the chemo on. And if that might be someone to look to. It's local, close by there at Mayo.
Thank you very much. I was in the beginning thinking Mayo Clinic, but unfortunately they're not a company that accepts the Blue Cross Blue Shield plan that I'm on. So I'm limited to, apparently MD Anderson is, but Blue Cross Blue Shield is not. They're out of network. That is, Mayo is out of network for Blue Cross Blue Shield.
Oh.
Who are you, Dennis, just forgive me for varying, but I didn't realize that Singh had left U of A and that he's gone up to Phoenix. Who's your treating doctor now at U of A?
Ahman, A-H-M-A-N.
Yeah.
I believe it is.
Yeah, he's been there a long time.
Yeah, he is. He's on the about ready to retire. And, that was another decision that I had to make. It's tough enough to find the best guy in Tucson, which was Parminder Singh at the time at the U of A.
Yeah.
And then when I heard he was leaving, that was kind of a downer for me.
Yeah, well, we can
have to rethink.
We'll talk about that next time, because I'm not a big fan of Armin from previous experience, so I didn't realize that you've moved back to him. But he's not that aggressive. He's not really up with what's going on today.
You're right.
He's stuck in the in the 1970s, and that's not good. Ken Anderson has a radio oncologist who suffers from the same syndrome, and so we need to talk as to.
So as far as chemo treatment is concerned, is it not something that almost anyone can give, or is it a specialty field as well?
It's not that it's a specialty field. I'm not sure if you were here for our first new guy. We talked a lot about what to expect, but you want a doctor who will work very closely and is willing to work very closely with Paul Korn at MD Anderson, and somebody who has a bunch of experience giving taxanes, because you get a situation like we just talked about with Frank. You want a doctor who's seen it before and knows what to do.
Oh, I got you.
And
well, hopefully Paul Korn can come up with a recommendation.
Well, that's right. I mean, I think that if Korn gives you the name, that's where you go.
Right. And then, my last question is in regards to Lupron. I was reading online one of the side effects is insomnia. Does that ring true?
Yes. Yeah.
I'll be damned.
And the reason for the insomnia is because you get woken up by the hot flashes. And even though you don't realize it, they're minor, they disturb your sleep, and sometimes you don't even know you woke up. A lot of times you don't even know you woke up. Now, if you're a guy who doesn't get a lot of hot flashes, that's not how it affects you, you're probably going to have an easier time with the insomnia than somebody who gets 20 to 30 or more a day or over a 24-hour period, or even more. I mean, I had a lot of issues. I got a lot of hot flashes, and I'd never slept well. And I would wake up in the morning feeling like a Mack truck had hit me. But in fact, it was because I just wasn't getting good sleep. So again, don't put the cart before the horse. See how you do. And if you find you have a lot of hot flashes and at the same time you feel you're not sleeping well, then we can talk about what to do to minimize the hot flashes, and hopefully that'll help you with the insomnia. Anybody else want to talk about that? There are plenty of experience on the call. Okay.
I get them on the back of my neck.
Say that again, Jake.
I get them on the back of my neck. I'm just starting to move in the hot flashes now.
Oh,
on Lupron.
Sorry, who was that was talking?
Jake Curran.
Oh, hi. Okay, I didn't realize you were even with us. So you're getting them right back to you. Anybody else want to talk about hot flashes and insomnia in the context of insomnia?
This is Richard.
Yeah, go ahead, Mr. Foodie, and then I'll come back to you, Jake. Go ahead.
Okay. Now, I don't know if you spoke to this gentleman about exercise, but when I first started taking Lupron, I had, what you described, like the hot flashes and problem sleeping. But the more that I exercised, that seemed to minimize over time. Now, I realize that, exercise is just it's not the same for everybody, but that might be helpful if he does, start experiencing hot flashes and having trouble sleeping.
Right. Right, and I think Richard is right on the money there, Ken. That the exercise can help you with the hot flashes. It certainly didn't. I don't want to say it didn't help me, because maybe I would have been even worse without the exercise. At the same time, let's just let's see how you do first, and if you have a big problem, because there are drugs, and there are complementary treatments that can address the hot flashes. Jake, go ahead.
I was just going to say, I've been on Lupron for about 4.5 years, and I had some hot flashes in the beginning, but as time went on, I got more used to it, and the hot flashes reduced to almost nil. So you may very well find out after a few months that you're not as susceptible to them. I'm getting them again now because I'm on a new drug, Xtandi. I'm starting to have hot flashes in the middle of the night, but they did subside significantly with the Lupron.
Okay.
So, just
anyone
word
else?
of possible encouragement.
Anyone else want to talk about insomnia and Lupron before we move on to Tom for our final?
This is Dennis. Just thing that worked for me that helped get the hot flashes too during the night, wakes me up, and that's inevitable. But taking melatonin has helped a little bit. I don't get a sound night's sleep all the way through, but it does help.
There you go. So that's the second testimony for melatonin that we've heard today. So there are, there are other things, and my advice again to you, Ken, is the same as I gave earlier. Talk to Paul Korn about getting a symptom management guy on board early. So, some call it palliative care, some call it symptom management, as we said earlier, but have a symptom management guy standing by, because they can help you a lot with these sorts of issues.
All right, will do.
Okay. And we're going to finish up now. We're 3 or 4 minutes over, but I know Tom Van Zandt still has a question. So Tom, tell us what's on your mind.
Yeah, it's not a question. It's a quick compliment to the call and a comment. Just to, I called in a couple of weeks ago because I started Xtandi, and I've been on it, I don't know, 6 months, and taking 4 pills a day, as most people do, and you always have to take them away from food, not with food. And there were comments on the call that it's perhaps not necessary to take that high a dose if you take some with food. And I asked my oncologist about a month ago on a visit, and he surprised me by saying, yeah, why don't you just take 1 pill with food instead of 4 pills without? And I said, gee, that's great, and I'll do that. And then I happened to get on the call that very night, and due to advice I got on this call, people said, well, that's nice that you're going to try that, but you should get your PSA checked every month when you're doing that. And only because I got on this call, I really hadn't thought of it. I should have known it myself, but because I got the advice from this call, I got back to the oncologist and said, hey, shouldn't I get my PSA checked every month since I'm changing and experimenting with the dosage? And he said, oh yeah, here's the prescriptions for April and May, you know, for your PSA test. And it's just an example of what you can get out of this call, or what you might happen to you if you don't check in with this call. The doctors let things slide, they let things slip, they're not thinking, and it's really good information that you get on here. That's it.
Thanks. And you said Xtandi, I think you meant Zytiga, right?
Thank you, Rick.
Yeah, I did, but my memory's shot.
Fortunately, mine is too, but fortunately I make notes as I go, so I can see, I have your medical record in front of me, or my version of it. But thank you.
I was going to ask the same question.
Yeah, thank you very much for saying that. And yeah, I mean, I think people can pick up a lot of information on these calls. I do believe that we really change lives. You know, I don't know how many of you happen to see the flash email that I sent out on March the 16th. We learned that Amazon Smile was giving 5% for any purchases that day. So I quickly sent out an email in the morning asking everybody to use Amazon on the 16th of March. I don't know if anybody saw it, and if anybody managed to buy a boat or a or a new car through Amazon that day, because we would have gotten 5%. But you know, if you're not on Amazon, if you haven't signed up, please sign up for us. And you know, we keep reminding you, if we're making a difference, think about a donation, because we're trying to grow, and I think it's going to be a short time, not too long, before we may be having to pull in more moderators and for this disease and other disease, and we may have to offer them stipends. So that's why we're pushing you all. But you know, these calls are free, and we hope you get things out of them. Just think about us as well. So that's it, guys. It's been I'm very sad, not sad. I'm disappointed we didn't get time to hear Jim Harrington talking about Listeria and Keytruda, which is the combination that he's doing. That's a really interesting combination. I'm anxious to hear how he's progressing on that, but that's something coming up for next time, and I may even ask Jim ahead of time to talk about it and spend 10 or 15 minutes telling us about it. Make a presentation. As a university professor, he's good at presenting, and so we can get him to present. That's about it. There are a couple of people I haven't even had the chance to welcome. I see some caller names on here. I'm sorry if we'd never heard from you, didn't get to you, but we see that you're there, and we thank you for being on the call. And our next call will be next Tuesday, right? Yeah, next Tuesday at 6 o'clock Eastern, 3 o'clock Pacific. I will have this call posted, I hope, since we don't have to edit anything on it, Jake. within about 2 hours, and we'll see you all next week. Okay? Take care, everybody. Oh, and Mr. Sibley, please get in touch with me so we can start guiding you to the right place.
Will do.
Okay. All right. Take care, everybody. Bye.
Okay.
Thanks, Rick. Good night.
Good
Bye,
night.
Rick.
Thank you.
Good night.
That was it.
Turn your mute on. You got
Well, I'm out.
Oh.
Okay.
Turn that out.
I'm not out. Okay.
Oh, where